So I want to start by welcoming everyone to this webinar on ethics and public health. My name is Paul Lebele. I'm an assistant director in the Office of Research Excellence here at the Milken School of Public Health at the George Washington University. I also teach ethics courses through the Department of Global Health. Welcome. So for some of you who have been attending these webinars, you might know that now we are talking about ethics and public health. Over the past 2 years, we're focusing on ethics and COVID-19. So we've now decided to broaden the scope of these webinars to focus on all the public health challenges that we are facing as a society. And today, we are focusing on monkeypox. In future, we might actually perhaps even go back to COVID-19, but we're going to look at all other public health challenges as we proceed. So today we are joined by two panelists who have written and will be talking about issues around monkeypox. So please, as we proceed with this webinar, I'd like to invite you to write your comments and also questions using the chat function. I'll be looking out for those questions and comments. And after the two presentations by our panelists, I'll then be directing those questions to our panelists. And this webinar is eligible for professional enhancement hours. So my colleagues are going to send information through the chat function on how you can go about submitting your professional enhancement hours forms to us for signatures. And these webinars are being hosted by the Office of Research Excellence here at the George Washington University and also the Bioethics Interest Group in partnership with the US and Mali Research Ethics Capacity Building Program, which is an NIH-funded program aimed at building research ethics capacity in Bamako, in Mali, and also in partnership with our research ethics capacity strengthening program in Kinshasa at the Kinshasa University School of Public Health. Now I'm going to introduce our first panelist, who is Professor Tyra Palmo. So she is an infectious disease physician and professor of medicine in the Division of Infectious Diseases here at the George Washington School of Medicine and Health Sciences. She is serving as the hospital epidemiologist at the GW Hospital. And she is a graduate of the University of Virginia School of Medicine. She completed her residency in internal medicine at the New York Presbyterian Hospital and a fellowship training in infectious diseases at the NIH. And she worked at the NIH for a good 20 years before moving to join us here at the GW in September last year. So she has been working a lot on the area of monkeypox, and basically here at GW is actually our go-to person on matters monkeypox. So I'm going to head over now to Tara, please.
Thank you so much for your introduction and for inviting me to join this webinar. I'm going to share just a handful of slides. Can you see my slides?
Yes.
Okay. So first, I just want to briefly share the current status of the monkeypox, I'm going to call it Mpox epidemic, that began in that was recognized in early May, but that actually began probably a few weeks earlier. So currently, there are more than 78,000 confirmed cases throughout the world. This includes cases in endemic and non-endemic countries. And in the United States, nearly 29,000 confirmed cases. By this time, actually, there are probably almost 30,000 confirmed cases that have, and those are recorded cases. There are probably well more than that have not been diagnosed and recorded. There have been 41 deaths recorded since the beginning of May, 13 in endemic countries, which is probably a far underestimate, and 28 in non-endemic countries. In Washington, D.C., there have been at least 519 cases recorded. I think those are data from last Friday, so probably a handful more. DC has had the highest per capita cases in the US because remember, we have 700,000 residents and 519 cases. Compare that to Virginia with 534 cases and I don't know, 20 million residents. So a lot more people than 700,000. Maryland has had 721 recorded cases. This is my iceberg picture to remind you that cases have been far underdiagnosed in many parts of the country. Cases overall in the United States have been largely diagnosed in men. Over 96% of cases in the US recorded in men, and the vast majority have been in men who have sex with men. Women are 3.4% of cases. That includes transgender women and cisgender women. And there have been 55 cases recorded in children under the age of 16. I'm showing you data from the CDC looking at the both ethnicity and race of recorded cases. So you can ignore the first bar because this represents only 4 cases. So starting early on in the epidemic in the United States, you can see that most cases were in, or a majority of cases were in white patients. So that's the dark blue here. And then as time went on, an increasing proportion of cases have occurred in Black or African-American people, which is the purple. And that's important because so now that represents about 44% of cases, and Hispanic or Latino cases are about I think about 20% at this point. And that's important because I'm showing you now a graph of pre-exposure vaccination. So pre-exposure vaccination, this is vaccination with the smallpox vaccine. So the smallpox vaccine has been around for decades, and that's how, in fact, smallpox was eliminated in the 1970s from the world. The smallpox vaccine, which is vaccinia, a related virus that's used to protect against both smallpox in the past and now monkeypox, is called Jynneos, and that's a vaccine that is in short supply throughout the world, including in the United States. More than 1 million doses have been administered in the US. Because of the short supply, the vaccine has been essentially sort of divided and administered intradermally rather than subcutaneously in order to administer very small doses and stretch the supply. There has been some focus on the disparity between the proportion of cases that have occurred in Black and Hispanic persons and the proportion of pre-exposure vaccine doses that have been administered in Black and Hispanic persons. And what you can see here in this graph also from the CDC is that a much smaller share of vaccine doses have been given in Hispanic and Black persons, it's about far less than half, about 1/3 of the total doses in Black and Hispanic persons. So, and there can be many reasons for that. So pre-exposure prophylaxis has been prioritized generally for the population most affected by Mpox, which again is men who have sex with men. And so giving 2 doses of vaccine is the full vaccine, considered fully vaccinated for this vaccine. More than about 2/3 of the 1 million doses administered are first doses. So many people have either not shown up for a second dose or have yet to receive the second dose for a variety of reasons. In this graph, these are people who've received at least 1 dose of the vaccine. Also on vaccines, I think the elephant in the room of ethical problems is the fact that that wealthy countries have not shared vaccine with countries where, both countries where Mpox has been endemic for decades. This virus was first identified in the 1950s, and while much of the world has only become aware of Mpox in the last 20 years, there have been outbreaks and endemic cases of Mpox in Africa, in Central and Western Africa for several decades. And so, but there's been no access to Jynneos, which is a much safer version of the smallpox vaccine than the old school smallpox vaccine that was used to eradicate smallpox. So while so that's a big issue, and the same is true of other parts of the world like South America, and other low and middle income countries have no access to this vaccine, which is actually it's so much safer than the old smallpox vaccine that can even be given in patients with HIV. So that's a big advantage. And the same is true of antivirals like the tecovirimat that's used to treat Mpox, which again is only available and accessible in wealthy countries. Moving to clinical aspect of monkeypox, signs and symptoms of Mpox are typically a 1 to 3 day period of fever, headache, fatigue, swollen lymph nodes, and achiness, followed by development of a skin rash. Now, not everyone follows that pattern. The skin lesions may be few and sometimes not scattered over the body, but isolated to the genital area, groin, or rectal area. And some people have throat infections, rectal infections, or penile infections. And a lot of that presentation develops on the site of inoculation. People who are prone to more severe disease include those with uncontrolled underlying eczema or atopic dermatitis, people who are highly immunocompromised, like those with advanced HIV, young children and pregnant women. Transmission, clearly there's human-to-human transmission. That's what we're dealing with, which is largely via skin-to-skin contact or mucosal surface contact with lesions present. There is the potential for transmission via oral droplets like saliva, and also from aerosolization or mobilization of viral particles on what we call fomites in medicine, which is really inanimate objects like bed linens. It's not transmitted on things like elevator buttons and handrails, of staircases and normal things that everyone is in contact with. It can also be transmitted from animal bites, and then there is a case report of human to dog transmission, but it's probably fairly uncommon. An issue that I have firsthand experience with and is by no means limited to any one facility or any type of facility is challenges of hospital care and clinical care of Mpox patients. These patients have, I can't underestimate how terrible these patients feel. They have a lot of pain. It's a very painful disease. Whether they have throat pain, especially if they have rectal pain, it's incredibly painful. Patients have described to me that it feels like shards of glass. And they feel also socially isolated. It's a very isolating and stigmatizing condition. And then, social media and the media in general has not made that better. Unfortunately, some healthcare personnel don't go into the patient's room if they're, in the hospital. And even if they're in a clinic, some healthcare personnel may avoid or try to avoid seeing those patients out of fear, out of really lack of education about the risk of transmission and how it's transmitted. It's not a new problem. I found an article from 2003 written by pediatric infectious disease specialists. So really almost 20 years ago, when a prairie dog related outbreak of Mpox in the upper Midwestern United States involving 48 people resulted in some children getting this infection. And they wrote this paper about healthcare workers not going in the room of a 10-year-old child who had Mpox. So this is by no means new and by no means limited to the United States. So, my personal mission in this regard has been to give a lot of talks, try to educate people, dispelling myths, also having personal protective equipment available, ensuring good infection control measures are in place so that people have confidence that that they won't be taken by surprise by a patient who has this infection is very important. What is the actual risk to healthcare personnel in non-endemic areas? Well, we know in endemic areas, there is actually a substantial risk to healthcare personnel because of a lack of PPE. That's a real risk. It's been documented by papers from endemic areas from well before this epidemic. In non-endemic areas, our personal protective equipment, this is actually me wearing it, N95 respirator, goggles or face shield, gown and gloves. We've only have a handful of occupational infections in healthcare workers documented in non-endemic areas ever. One was a nurse in the UK infected when she handled bed linens of an infected patient in 2018 without wearing any personal protective equipment. One was, and then there were 3 during this epidemic in the United States who were infected from needle sticks when they were using sharp objects, I guess they were needles, for unroofing skin lesions, for opening up skin lesions to test them with swabs, which is actually not a recommended technique. And then accidentally stuck themselves with the needles and became infected with Mpox. So the CDC sent out an alert saying, please don't do that. Healthcare, there's a very elaborate and but still easy to follow healthcare personnel risk assessment that from the CDC that's performed after any exposures, and healthcare personnel are then monitored for 21 days Out of many exposures, these are the only documented cases of transmission. Post-exposure vaccination with the vaccine is performed after high risk or intermediate risk exposures. And at GW Hospital, I can tell you, we've had a couple of exposed healthcare workers. So exposures occur when someone turns out to have this infection and healthcare workers have been in the room without all of that PPE. And then they get post-exposure vaccination when it turns out that the patient actually had Mpox. And a risk assessment classifies the healthcare worker as having had a high risk exposure. And we have had no transmissions. So finally, I want to tell you about a case that I have learned about of a patient with Mpox with appendicitis that brings up really when a situation when these avoidance issues collide with a patient's well-being in a very concrete way. So this is a 42-year-old man who presented to a clinic with mild proctitis, which is rectal infection, and a few scattered skin lesions, and underwent testing for Mpox, which then turned up positive the next day. When the patient was being told his result, he reported that he had new onset right lower quadrant abdominal pain, which is actually a pretty classic description of appendicitis. So he was referred to the emergency department, where he then went and had findings consistent with appendicitis. He was seen by the surgeons. He was treated with the antiviral for Mpox, Ticovir mat, and IV antibiotics for the appendicitis. The surgeons examined him every couple of hours, as they do, and booked an operating room for an emergency appendectomy because he was getting worse. However, the anesthesiologist raised an objection to the surgery, citing occupational risk of Mpox transmission in the OR. They made a case that the patient should just be treated with antibiotics instead of surgery. Surgeons argued that surgery was preferable because the patient was getting worse on antibiotics before their eyes. The impasse was finally broken at the executive level of the hospital after several hours delay. The patient underwent surgery, but by that time, the appendix had ruptured, and there were no occupational exposures. In the end, the patient did fine from the in the immediate short term, but then 2 weeks later, returned to the hospital with an abscess in the site of the ruptured appendix, which is exactly what happens if there's a ruptured appendix. And had to have a drain placed and 3 weeks of intravenous antibiotics for that situation. So that is all I have to say, and thank you very much.
Thank you very much for clearly describing the magnitude of the problem. And you have also clearly explained how the challenge of monkeypox is mainly affecting men, and especially men who have sex with men. You have also addressed the issue of the short vaccine supplies, but also the issue that those countries that always have cases of monkeypox actually do not have access to these vaccines that are actually in short supply. And of course, you ended up with a very, very interesting case, which was focusing basically on that particular patient. Is actually magnifying the problem here, particularly for patients who have tested positive, and the fact that even healthcare personnel are concerned about taking care of such patients. So thank you very much for clearly explaining all these issues. So I want to encourage our participants to please write your comments and questions using the chat function. We'll get to those questions after our second panelist. So now I'm going to invite our second panelist, with Professor Michael Ulrich, who is an assistant professor of health law, ethics, and human rights at the Boston University School of Public Health and the School of Law. So his scholarship mainly focuses on the intersection of public health, constitutional law, bioethics, and social justice, with the emphasis on the role of law in the health outcomes of marginalized and underserved populations. And here we are also looking at the issue of the marginalized populations, particularly when we look at men who have sex with men. And these writings have appeared in both national and international journals. He has got various positions, and interestingly, he also served as a bioethicist in the Division of AIDS at the National Institute of Health. And I also served in that position around 2012 and 2013. So welcome, Michael, please go ahead.
Thank you. Thank you very much for the introduction and for having me. A lot of the information that Dr. Palmore described and the ethical issues that it raises really in a lot of ways aren't things that are new, right? We've seen these in a lot of other diseases, but I want to go through some of them. So the first is the racial disparities that were raised. And one of the problems is the link to the outcomes of these diseases when these outbreaks have, and the conditions that exist before those outbreaks occur, right? So marginalized, underserved populations are at greater risk of both contracting these diseases, of not receiving proper treatment, of having, exacerbated effects from these diseases. And so a large part of what I'm going to sort of be talking about at multiple points is the need to think beyond just the disease itself, but the way that these diseases interact with these other disparities that exist in our country. The other thing for this kind of disease is the issue of sexual transmission, right? And what happens when we sort of label something an STI versus sort of a contagious disease. And in one sense, there's an article in New England Journal of Medicine just recently talking about this, that this is really important to make it clear to the public this is an STI so that they have information and they can be proactive in terms of the behavior that they undergo and the protections that they undertake. But it's also important to be mindful of the stigmatizing effect that can have, especially for men that have sex with men. And so work that I did, for example, in Mississippi, a while ago, dealt with the spread of HIV and the rates of HIV, especially in men that have sex with men in Mississippi. And part of the issue was the stigma, and not only in terms of the disease itself, but of being gay, and a lot of people hiding it. And so, we had a lot of cases, or we found a lot of cases of people who were avoiding treatment, for example, because a clinic is known as the HIV clinic, and therefore, if somebody were to see them to go there, then they're going to think that they're gay, whether they are or not. And so the social ramifications of that. And so, again, beyond the disease, we still have a lot of work on destigmatizing diseases and the diseases themselves, but also things like being gay, for example. And so, and where that might not be as much of an issue in DC, or San Francisco or New York, it certainly is a big issue in other areas. And so we need also to remember that how we address these sort of things is going to take some local understanding as well, right? We can't sort of say that the same approach can necessarily be useful around the country. I think that's important to keep in mind. Vaccine shortages is something that was also raised. And so determining who gets these vaccines, right? And that is going to require outreach into certain communities, especially communities of color, right? That have a poor history with science, medicine, research, public health. And so again, we need to be more proactive. There should be a constant engagement with communities of color to build up trust, to build up public health infrastructure, so that when these outbreaks happen, we don't have that sort of lag in terms of vaccination rates because of that sort of hesitancy that we often see in communities of color. And especially when you have vaccine shortages, right, you want to identify those that are going to be most at risk, but you also need them to be engaging with you and to be trusting the public health and medical community. Another thing that becomes problematic, especially with vaccine shortages, is this dynamic of who gets the vaccine and who doesn't, and how to prioritize. And something like this, again, the risky behavior of unprotected sex, having multiple sexual partners, puts you at higher risk. And so that's the population that you should target. But the sort of less risky population often has trouble accepting that, right? And so helping to educate people to say, not only do we have a shortage, but also, you're not really at risk, right? Or here are these very sort of simple things that you can do besides vaccination that would help sort of protect you while we are sort of prioritizing these other populations. And this comes up in public health a lot, right? This idea of personal responsibility. And so if you're engaging in risky behavior, why should you be prioritized over those that aren't engaging in risky behavior? And so again, the need to sort of have the public understand the specific and direct risks of these diseases, the populations that are at risk, and what can be done. Vaccination, almost always important if it's available, but there are a lot of other measures. And again, we've seen this in other diseases, right? So if you think about the Ebola, quote unquote outbreak that happened, back in, I think it was 2016, we had 4 cases in the US, but we had 18 states passing extremely restrictive laws about quarantine and what to do with people. And so, it's a scary disease, but people don't understand the difficult or the way that it actually can spread, and the fact that the vast majority of people then aren't actually at risk. You had questions about people flying on planes and things like that. And so where again, they really weren't at risk. And so that can also play a significant role in determining, or the public reaction of these sort of prioritizations in vaccine shortages. The other thing for proactive approach, especially for anything that is an STI or can be spread through sexual contact, is we don't have a great sexual health infrastructure in this country. And that's sort of diagnosing and treating, but also it goes all the way back to sex education, right? And so this is something that I really think that the public health and medical community can do, can engage with more. Because oftentimes, again, in specific communities, right, sex is just something that's not talked about as if it doesn't exist, and that puts people at risk, frankly. And so if you have things like it's difficult to access condoms and things of that nature, that isn't always going to prevent people from having sex, and so it puts them again at greater risk. And so sex education and increasing access and better understanding of how to have safe sex, I think is really important. The other thing that was mentioned by Dr. Palomore is thinking about vaccine accessibility both in the United States but also abroad. And so another issue that again is for this disease, but every other disease, is the degree to which the United States is engaging with other countries to, again, proactively help them build their infrastructure, access and have resources, because, even if you don't think that's the ethical or right thing to do, it is protective of the United States, right? The sort of America first approach in public health is simply not going to work, right? We have increased travel. You can get from one, side of the world to the other in a flight. And so, diseases don't understand national borders and they don't care about them. And so this idea that we can just sort of focus within the United States, and that's going to help us address, prevent, and deal with any sort of outbreak is just completely inaccurate, right? And so we need to do a better job of engaging and helping in other countries, but also, again, getting that sort of political and public will behind it by helping people understand that is both sort of beneficial to those countries, but also extremely beneficial to to us. And the other thing that I wanted to address was this idea of the healthcare worker who did not, the anesthesiologist who didn't want to engage and treat the patient that had monkeypox and appendicitis. And this is sort of a growing concern of mine. I'm not a doctor, so I'm not in these ORs, but I am a lawyer. And so, and what we're seeing more in the law, but in, health law, public health law in general, is this increase in both sort of encouraging and protecting personal beliefs. And this is, this is dangerous for medicine and for public health. And so for me, I was thinking about something like flu vaccine mandates of healthcare workers, sort of pre and post COVID. Pre-COVID, you started to see them kind of spread and be taken up by more and more hospitals, and there were always people who challenged them, but courts widely upheld vaccine mandates in general, but including for healthcare workers. And now during and post-COVID, we're seeing an increase in sort of rejecting these vaccine mandates, but we're also seeing an increase in courts accepting that vaccine mandates maybe aren't constitutional and aren't viable at the city level or the state level. And it hasn't become widespread, but it's something that could continue to grow and spread. And if that is the case, right, then it could limit the ability of states or hospitals to implement any sort of policies that go against a personal belief. And so again, in this sort of case, if someone says, I am afraid that I'm going to catch this, how much does, your risk is basically negligible, right? If you wear these, the proper PPE, does that matter or not? And again, increasingly, that's becoming less salient in some of these court cases. And so if we see increased protection of, I have religious refusal rights for not only abortion, but to provide and providing contraception, but also to treating men who have sex with men, right? Or things like that. And again, that is something that is increasing during the COVID era. And I think one of the issues of COVID was, again, a lot of these ethical problems are not new in that the othering infectious diseases has always kind of been common. This issue of these are diseases that come from some other country. They, are not the United States' fault, whether that's right or wrong, and it's mostly wrong. And the people that get them, right, it's from some sort of risky behavior that really kind of then allows us to place the blame on them. And then it's a small population, right? And so again, if we think about Ebola, you had people across the political spectrum saying, essentially lock those people up, right? Put them away, protect the rest of us. And that's kind of how we've dealt with things in the country, right? It's a simple binary of protect the uninfected at the expense of the rights, well-being, and ethical considerations of the infected. And the thing that's interesting about COVID is what changed that is you can't do othering when you have millions and millions and millions of people that all become infected, right? And so there was a shift to, well, now that I'm at risk and I could be or am included in the infected, I don't want any rights restrictions. I don't want, no longer, right? And so it's interesting to see that for Mpox, we're kind of back to that. Well, this is a small population, a population that's already stigmatized and marginalized to some extent. So it's easier, and we have to sort of push back against this othering and this sort of, hey, let's just leave them on antibiotics in that room and, see if it works. And so that is another big concern of mine that we didn't really necessarily learn some of these important lessons through the COVID pandemic. And so, those are just sort of a few of the considerations and the concerns that I have. And I think I'll just stop here so we have time for some questions. Thank you.
Thank you very much, Michael, for all those comments. And I just want to, if I can summarize On all that we have said, we're actually emphasizing on thinking of the person beyond the disease. It actually lists all these issues about othering, because this othering comes about because they're actually not thinking about the person who is actually infected or affected. We are thinking about the disease. There is lots of fear and so forth. And you're also emphasizing on the issue of taking the context into consideration when crafting the messages, and particularly also emphasizing on the issue of engaging communities and building relationships so that we prepare for future, pandemics. But we also touched on the issues around access to vaccinations and also issues around, sex education. Importantly, we emphasize on the issue of accessing the vaccines within the US and globally, and what can actually be done to ensure that we have a safe globe. Whenever we have outbreaks in other countries, we end up also getting infections even here in the US. So by taking care of those outbreaks in other countries, we are also at the same time addressing our own challenges. So now I want to go into some of the questions that have been asked by some of our participants. And the first one is kind of a basic question that seeks to understand the transmission from the animals to the humans, particularly when you're looking at monkeypox. How can you explain the movement from the disease that is the monkeys to the humans? So that's the first question. I might actually direct this at Tara. Yes, please go ahead.
So the question is, how do humans get mpox from animals?
Yep.
So in endemic countries, humans are infected by animals through bites and also through hunting, bushmeat, and skinning animals. And it's often young children that are infected through bites and through catching animals. And then the rest is human to human transmission. And in fact, there's also been animal to human transmission in the United States. I alluded to the 2003 outbreak in the United States when imported West African small mammals were housed with prairie dogs in Texas. I think it was in Texas. And then the prairie dog and infected the prairie dogs. And then the prairie dogs were adopted as pets. And all of a lot of the humans that were associated with the small mammals from West Africa, the prairie dogs, so the families that adopted them, the veterinarians, the animal handlers, became infected. And so there was an outbreak of 48 people who, through bites, through close contact with those animals, developed mpox in 2003. So that's an example in the United States. That's the first outbreak of mpox in the United States. But that's just sort of a an example in a non-endemic country. In endemic countries, it's usually through wild contact with small mammals like Gambian pouched rats and other endemic small creatures.
The second question relates to the issue of clinical trials aimed at addressing monkeypox. Right. So there is one participant who is asking the question about the conduct of these clinical trials in countries where this disease is endemic, and particularly focusing on African countries. Say, have there been some trials that have been conducted there? And if those trials have been conducted, are these countries benefiting from the end products? We're looking at even this particular vaccine, which is still in limited supply. So
Should I answer that?
Yeah.
Yeah, I'll give you a short answer to that, which is there have been clinical trials. There's been a clinical trial of Jynneos, of the vaccine, I think it was in the DRC. And there is currently, this isn't the vaccine, but there is currently a clinical trial of tecovirimat, the antiviral, ongoing in the DRC for Mpox cases there, just as there is in the United States. That just started in, I believe, in September or October. So that's an NIH clinical trial. And the first was, I think, a CDC or NIH trial, the Jynneos trial, which took place well before this outbreak. So there have been clinical trials.
I'll just add briefly that separate from, again, Mpox, because the general issue of research in other countries and sort of what do they get is, again, not new. And so there's a lot of literature out there about fair benefits. So do you build infrastructure within the community that you're testing in, or can you build, watering holes, right? Does it have to be related to the research? Issues of ancillary care have been discussed. Henry Richardson, people like that, about, what about providing care beyond the sort of narrow scope of the study that you're doing? And then, of course, post-trial access. And so I would just say this is an important issue, absolutely. And but again, nothing new. And so I would certainly encourage you to look into the literature of these things, because it's something that even within the bioethics community is debated about, what can or should be done, and are there certain things that should be focused on more than others?
Thank you, Michael. So that's what that even as more trials are being conducted, these issues are factored in to those trials, so that at the end, we don't see these countries that are participating in these countries not having access to these interventions. There is a question here about the issue of misinformation. So particularly when we're looking at Monkeypox, I've heard issues of misinformation, and the specific question here has to do with how you address and confront misinformation regarding disease, but also at the same time maintaining freedom of speech.
Yeah, it's a great question, and this really is this is something that is maybe not new, but is more of an issue now than it's ever been, especially with 24-hour news network and social media, and it's difficult because as far as what the government can do in restricting specific speech, they're quite limited. Speech is incredibly protected, and so the government can't sort of come in and say, here are the people that can talk and here are the people that can't, or we're going to ban one news station or somebody from talking on any given news station. And so and then when you think about social media, those are private companies, right? And so the government is limited to some extent what they can get the private companies to do. And so we've seen this on Twitter and Facebook, for example, them trying to find this balance. Now, again, they're private companies, so the First Amendment doesn't apply to them, right? They are companies, they can do whatever they want. The First Amendment is only for government, restricting government action. But even within, sort of their business, they're trying to find that balance between, we don't want to lose anybody, but we don't want sort of backlash of helping to spread misinformation. And so Facebook and Twitter tried to kind of have different approaches to flagging things, but especially with the shift now to Elon Musk, that kind of highlights who's deciding what qualifies then in these private companies as misinformation or not misinformation, or how their algorithm is used to promote certain things versus others, is a really big problem. And there's been a lot of research into this, that the more inflammatory, the more hostile your message is, especially on something like Twitter, the more likely it is to get noticed and the more likely it is for people to see it. And so in that sense, in this kind of social media addiction of likes and retweets and attention, misinformation is encouraged, essentially, even if it's not directly. And so it is a really big problem. I think that Congress is considering certain ways to deal with the big tech companies. But frankly, at this point in time, the the best solution is, again, for public health and medical experts to get out and talk to people as much as humanly possible, right? Whether it's on social media, doing webinars. Palmore has, worked nonstop on this, going on news networks. That is the best way at the moment for countering misinformation.
Thank you, Michael. So the next question, I'm not going to direct it to the two of you, but starting with Sarah. So you mentioned that the majority of people that have been infected so far are men, and especially men who have sex with men. So I'd like you to comment on the interventions that have been implemented so far in order to reduce the spreading of monkeypox. You are muted, yeah.
Sorry, can you repeat the question, Paul?
Yeah, I wanted you to comment on the interventions that have been implemented so far, particularly focusing on men, right, to ensure that we reduce the spreading of monkeypox.
It just in general.
Yeah.
Yes, certainly. Well, the pre-exposure vaccination called PrEP++ has been I think very effective in some areas, some communities, and then I think also the I think that really the gay community has taken this on as and really owned the communication and owned the education. And so the partnership between public health and that community in terms of advocacy and education has really helped to has helped both get the message out about vaccination and also to some extent probably behavior changes that were needed to stem transmission. In addition, I think public health departments in, I can't speak to every public health department, but I can speak to certainly like New York and DC, the ones that I know of, very well, really tried to message, to target messages to the communities most effective, and also to open vaccine clinics in neighborhoods where the most highly affected people might have better access. Another thing that the CDC has done more recently, like in October, is tried to pivot messaging so that people who are maybe more averse to self-identifying as men who have sex with men would feel more comfortable getting vaccinated. So they've actually changed, opened up, encouraged public health departments to open vaccination a bit more widely so that people wouldn't have to self-identify in order to be vaccinated, which previously was a requirement.
And Michael, any other comments, particularly focusing on the issues around stigma?
Yeah, I think Dr. Palmore raises an interesting point. Again, how you would approach this in DC and New York is going to be quite different than national approach and in other areas. And so I think engaging with the LGBTQ plus community, right, and really getting them to embrace it has been incredibly effective in those larger cities. But again, in other areas and worrying about those that don't maybe self-identify or still feel like they need to be closeted because their community, you do need a different approach. And so I think that's why you see kind of this shift that the CDC is making.
Thank you. There is another interesting question which simply shows that as society and as public health systems, we are often caught unprepared. So there is a question here about how we can improve our healthcare system so that we are better equipped to address current and future public health challenges, including those involving stigma. So we've already addressed issues around stigma, I think, during the previous question. So as we wind off now, I'm going to give each one of you just a minute to focus on that particular question as your parting shots. I will start off with Sarah.
That's that's a question that's bigger than me. I think you know, everyone has looked at this pandemic, the COVID pandemic, and then the Monkeypox pandemic, and you know, asked ourselves, how can we improve our healthcare system so we're equipped to address future public health challenges? And I think we all worry that we're not addressing, we're not improving anything so that we will address future public health challenges, that we're doing everything the same way. And I think that is a real danger. There are so many issues. I think one of them is really fundamentally addressing health disparities. And I think we get nowhere in addressing future public health disparities, public health challenges, until we address that, because those will continue to really recapitulate themselves every time we have a pandemic or an epidemic. Every single time we will see that we will, you know, have to continue to be surprised by the healthcare disparities that show themselves manifest in many different ways in every epidemic, including you know, and the stigmas that you know, that Michael you know, reminded us that we saw during Ebola, that we have seen during COVID and then during Mpox, all different types of stigma. So but until we address healthcare disparities, you know, nothing else will really improve.
Thank you very much. And Michael, your parting thoughts?
Yeah, I agree with everything that was already said, but you know, I think part of what's going to be important is the shift from focusing, frankly, on the healthcare system to public health and public health infrastructure. The healthcare system, right, can be better, and you know, we shouldn't have anesthesiologists refusing to go into a room until somebody's appendix bursts, but we also need to shift a lot of the resources that are going into treating after the fact, and instead trying to prevent, you know, specifically, again, these disparities, and you know, not only in terms of health outcomes, but income, education, transportation, all of those things. You know, social determinants of health are real, and they contribute. And if we're addressing those in an ongoing manner, whatever the next disease is that starts to spread will have a smaller impact, and will specifically have a smaller impact on those communities of color and the poor and those that already suffer from being marginalized, minoritized, and from health disparities.
Thank you so much. So,
thank you for having me.
We've now reached the end of our webinar, and I would like to thank our panelists, Professor Palmo and Professor Ulrich, who have been with us to share their interesting views on this topic. I would also want to thank all the participants. I see we have participants from different countries. Thank you very much for joining us, and thank you also for all those persons who couldn't tackle all of them. But this was just an appetizer, so that we continue discussing all these interesting and yet difficult questions. So let's look out for the next invitation to the next webinar. For now, it's goodbye from me. Thank you so much. Bye-bye.